Hello, this is Brad Vazalis, cardiovascular surgeon, intensivist, and founder and CEO of ENDOCLEAR LLC. In this PowerPoint, I will demonstrate the new ENDOCLEAR Liberator closed airway maintenance system, the use of which results in improved care of the artificial airway. I would first like to demonstrate the components of the Liberator system and how these components function to provide access to the tracheobronchial tree and to allow several different procedures, all without the de-recruitment, lost tidal volume, and decreased PO2 that can occur with other systems that require interruption of the patient ventilator circuit to instrument the airway. I'm Brad Vazalis, cardiac surgeon and intensivist, and I'd like to review the use of the modular ENDOCLEAR Liberator airway maintenance system. Any patient who is intubated and brought into the ICU is connected initially to the ENDOCLEAR closed suction system, which is a modular system that starts with this manifold. There's this double swivel. Additionally, there is a stopcock that completely isolates the ventilator circuit from any module that is subsequently attached to the manifold. Initially, the closed suction module is connected. It can be either 12 or 14 French. There is a 180-degree lock controller, a wedge for removing the endotracheal tube in times where it would be stuck and would need to be removed, and the other feature is a gown clip that we can use for early ambulation of the intubated patients. When the patient requires suctioning, the stopcock is turned and the suction catheter is advanced, and if shallow suctioning is done, the markings of the suction catheter are lined up with those on the endotracheal tube. In cases where deeper suctioning may be required on clinical basis, obviously we can then suction more deeply into the lung. The suction is deployed, pulled back into the cleaning garage, and the stopcock then turned to close off the module from the manifold. At this point, additional suction passes could certainly be made. Once the clinician is satisfied, we recommend 15 cc bullets because of the additional volume of cleaning. The cleaning garage is elevated slightly so that the suction holes are in a dependent position and the saline is squeezed while suction is being applied to the cleaning garage, and this is done until the catheter is visibly clean. In patients that require additional maintenance of the endotracheal tube by removing the secretions that closed suction invariably leaves behind, we have the Liberator module that will need to be attached to the manifold. The Liberator catheter has a sterile cap. The catheter itself is somewhat different than closed suction in that we can deploy the wiper and then pull it back through the endotracheal tube in order to remove the retained secretions. When the arrow points to the ISO standard for lock, neither the suction nor the wiper can be deployed. When the arrow lines up on the balloon can be deployed, but the suction doesn't work. And when we're on suction, the suction works, but the balloon cannot be deployed. When it's turned back to lock, neither functions. When the Liberator is required to be used, the sterile cap is removed. It's placed on the closed suction system, which is then placed on the working area of the patient in bed. The Liberator module is connected. I usually move this to get it a little bit out of the way for advancing the catheter. The stopcock is opened, and because the catheter is silicone and not as firm as the suction catheter, the way this is advanced is to advance the catheter and to gather the sheath onto this area, which is a small plastic tube, and you can gather the sheath as you advance. The initial time the Liberator is used, the centimeter markings are lined up with those on the endotracheal tube. And once those are lined up, we know that the wiper is positioned appropriately. At that time, we also look in the cleaning garage window and are able to see a centimeter marking, which in this case says 38. What can subsequently be done is that every other time this device is used, the catheter can be inserted up to the 38 in this window and know that it's in the correct position distally. Once that's been done, the control is turned to wiper, and with a patient inspiration or a ventilator inspiration, the wiper is deployed and pulled back into the cleaning garage, and the stopcock is closed. At this point, the cleaning procedure is done by moving the control to suction. The 15 milliliter saline bullet is placed. The manifold is elevated slightly so that the suction holes are dependent, and suction is applied, and the saline is rinsed, and all of the material that has been accumulated from the tube will then go into the suction and into the wall waste. Once that's been done to visually clean, the device can be put back to lock, and the closed suction can be reconnected. The sterile cap goes on the 72-hour Liberator device, which is then stored offline in a storage bag that says ENDOCLEAR. You're able to see what device is inside and in fact read all the numbers, including the 72-hour sticker that would be placed right here on the suction control. And there is a hole in the bag so that it can be hung up on the ventilator or with the oral care or in any convenient hanger in close proximity to the patient or where it would be used. So, in the event that the material inside the cleaning garage is so tenacious, bloody, etc., that the catheter can't be cleaned, the other advantage of the modular system is that it can be disconnected, the catheter advanced, and a sterile 4x4 can be used to physically clean the catheter and then reconnect it to the manifold. This can help potentially save a catheter for its full 72 hours of use. Intubated patients sometimes require instrumentation of their airways, either for bronchoalveolar lavage or bronchoscopy while in the ICU. This is the ENDOCLEAR bronchoscopy adapter that works with the ENDOCLEAR Liberator airway maintenance system. The bronchoscopy adapter is also a modular component of the system. It has a flexible diaphragm that accommodates size instruments between 3 and 8 millimeters, and once the instrument is inserted, it is air tight to 40 centimeters of water pressure. It comes with a sterile cap, and when the patient requires bronchoscopy, first we know that the stopcock is closed. This means that the ventilator circuit will not be compromised so that we can do these types of procedures even on patients with ARDS that have very high oxygen requirements and high PEEP, for example. So the sterile cap is removed. Once again, the closed suction is disconnected and placed on the working area, and the bronchoscopic adapter is placed. The instrument is inserted into the adapter and the stopcock is opened. Subsequently, the procedure is done, and once the bronchoscopy or BAL has been completed, the bronchoscope is brought back into the adapter, and once again the circuit is reestablished. At this point, the adapter can be disconnected, the bronchoscope sent away, or if desired, the scope itself can be cleaned within the cleaning garage by using the 15 cc bullet. If this were a BAL catheter, one could get additional specimen by flushing and suctioning through the catheter itself before disconnection. Once the disconnection is made, the closed suction is reconnected to the manifold, and through all of that, no ventilatory function was lost. Now that we have reviewed the function of the ENDOCLEAR Liberator system, we will investigate why use of the system results in safer airway management, improved patient outcomes, and lower hospital costs. This is a short video demonstrating the inadequacy of current standard of care closed suction to maintain optimum patency of the endotracheal tube and how the Liberator system solves this problem. This is an 8 millimeter endotracheal tube inside a see-through model of the human head and trachea. I'm going to connect a standard suction system to that. This is actually a 16 French catheter. It's very stiff. Can conceivably do injury if put too far out the end of the tube and into the carina, for example. And now I'm going to apply suction to the end, getting any material off the end, and then pull it back through the tube. And as I think you can see, after that one pass at a suction level that is recommended by the AARC for adults on the order of 150 to 180 millimeters of mercury, there is still residual synthetic secretions, just like there are residual pulmonary secretions after a pass of the standard suction catheter. I'm now going to connect the ENDOCLEAR Liberator device, which is a hybrid system that has both suction and endotracheal tube cleaning. So what we are going to do now is to pass the ENDOCLEAR device in the same way, and we are going to turn the controller to wiper only. Now we're going to inflate the wiper and then pull it back into the cleaning chamber. And now I'm going to go to suction and apply suction to get any of the material that's residual in the manifold. Now I'm going to close the manifold, and a 15 cc saline bullet is connected to the injection port of the cleaning chamber. We elevate it a bit so that the cleaning chamber is in a downward direction towards the suction holes in the catheter. And then as we apply suction to the cleaning chamber, we flush the cleaning chamber with saline. The saline bulb is removed, and as you can see, the residual pulmonary secretions have been taken into the suction catheter and the wall waste by using suction applied at 150 millimeters of mercury. We now have a fully open endotracheal tube at the lowest work of breathing possible for that size tube, and we have a clean suction catheter in its cleaning chamber ready for its next required use. As we have now seen from the two demonstrations, the manifold system allows use of a closed suction module, a Liberator ET tube cleaning module, and a bronchoscopy module without alveolar de-recruitment. Additionally, the manifold system allows catheter cleaning without unintentional lavage of the tracheal bronchial tree, because when the stopcock is closed, no saline can be lost into the endotracheal tube and drip into the lungs, carrying with it bacterial and fungal elements. This clinical example shows the consequences of retained endotracheal tube secretions. The patients whose tube is visualized here had undergone 6 days of mechanical ventilation, utilizing standard of care closed suctioning for maintenance of the airway. Adherent secretions developed and lined the endotracheal tube, and the patient failed spontaneous breathing trials on a daily basis. She then self-extubated and did not require reintubation. The ET tube that you see here was cleared with an ENDOCLEAR device, and as you will see, significant amounts of material were removed, which almost certainly contributed to her daily weaning failures, secondary to the increased work of breathing experienced. What is shown here are the opening remarks in the AARC Clinical Practice Guidelines for suctioning intubated patients. The red highlights acknowledge luminal decrease from secretions in biofilm, but also acknowledges that suctioning is inadequate to prevent it. They also note that not only is suctioning not effective, but can be dangerous. The primary goal of mechanical ventilation is to reduce the patient's work of breathing. The total work of breathing in the mechanically ventilated patient consists of the patient's own physiologic work of breathing, which is generally a given according to underlying patient factors, the disease process that the patient is suffering from, which is often modifiable, and the resistance offered by the ventilator circuit and endotracheal tube. This is known as the imposed work of breathing and is clearly modifiable. The significance of endotracheal tube narrowing and its effect on work of breathing is defined by Poussey's equation. Even the smallest decrease in endotracheal tube diameter can be accompanied by substantial increases in work of breathing. This article in Chest out of West Virginia University in 2009 shows us that secretion buildup in endotracheal tubes is common and can result in marked increases in airway resistance. These researchers also found that obstruction can occur quite early and is not entirely predictable by patient characteristics. This article out of Massachusetts General Hospital used high-definition CT to confirm that endotracheal tube obstruction is common and widely unrecognized, and that current suction systems are unable to maintain endotracheal tube nominal function. As important as endotracheal tube narrowing can be, that is not the only issue with current standard of care treatment. We now know that nearly all endotracheal tubes develop biofilm, which has been implicated in the pathophysiology of ventilator-associated pneumonia. We also know that biofilm matures through 4 stages, with stage 4 being associated with pneumonia in the ventilated patient. This maturation may occur quite quickly. This article in Respiratory Care investigated both the obstruction and the biofilm components of artificial airway deterioration. They found that biofilm is always present in endotracheal tubes, it's quite adherent to the inner lumen of the tube, and that the average total volume loss was about 7%, which corresponds to between 1 and 1.5 cc's of retained secretions. Now that we understand the ubiquitous nature of the problem and the inadequacy of closed suction to maintain artificial airways at their lowest work of breathing, let's look at why addressing this problem effectively results in improved patient outcomes. This study out of West Virginia University suggested that clearing the endotracheal tube could be an adjunct to closed suctioning and could both reduce endotracheal tube occlusion and minimize colonization. The furthest left photo is of an endotracheal tube from an in vitro patient ventilator model in which the biofilm was created using bioluminescent Pseudomonas aeruginosa. The middle photo is of the endotracheal tube following one cleaning pass with an ENDOCLEAR device. The last photo on the right shows the amount of secretions that were obtained with one pass of the ENDOCLEAR device and that were not removed by closed suction. This study from 2012 by Massachusetts General Hospital researchers showed that the mucus shaver, which is a wiper very similar to that on the ENDOCLEAR Liberator system, can significantly decrease bacterial colonization and biofilm formation in the endotracheal tube. They concluded that the wiper was safe, feasible, and efficient to help prevent microorganisms from finding a home in the artificial airway. This study from the McLaren Hospital System in Michigan showed that clearing endotracheal tubes with ENDOCLEAR devices resulted in decreased airway resistance and work of breathing, and provided a rationale for why patients might be liberated from the ventilator sooner if their endotracheal tubes were cleared prior to their spontaneous breathing trials. I would like to review one of the largest evaluations of augmented endotracheal tube maintenance that we have to date. The Johns Hopkins Armstrong Institute for Patient Safety and Quality was awarded a 3-year contract from the Agency for Healthcare Research and Quality, AHRQ, on a project for a comprehensive unit-based safety program for mechanically ventilated patients. The program was called CUSP-4 MVP-VAP. The purpose of the study was the nationwide dissemination and implementation of CUSP to prevent VAEs, including VAP. The project goals were multiple, and I would like to focus on the duration of mechanical ventilation and length of stay, as these were the 2 areas in which it was felt that the data was most complete and reliable. Pictured is the CUSP wheel, which is largely based on the Vanderbilt ABCDEF initiatives to improve ventilated patient care. Cohort 2 in this study included 52 hospitals and 18,626 patients, and was performed over a 19-month period. Included in Cohort 2 was the 10-hospital McLaren system in Michigan. For 19 months, the 10 McLaren hospitals did all the same webinars, meetings, and improvement initiatives as the other 42 hospitals in Cohort 2. The only clear difference was that the McLaren system had already committed to daily cleaning of the endotracheal tube with an ENDOCLEAR device at the time of the morning SAT and SBT. During the 19 months of the initiative, the 10-hospital McLaren IDN achieved a length of intubation that was a full day shorter than that of the other 42 facilities. As the incremental cost of being in the ICU, but also on a ventilator, is at least $1,500 per day after DASTA, this resulted in a huge comparative cost savings for rendering this care. Similarly, the McLaren IDN experienced a one-day lower average length of hospitalization for their intubated patients than the other 42 hospitals in the cohort. This is likely because extubated patients can earlier and more completely engage in the in-hospital rehabilitation needed to be able to return to activities of daily living on discharge. In summary, the McLaren IDN, utilizing ENDOCLEAR products, were able to demonstrate the benefits and improved objective outcome measures compared to other hospitals in Cohort 2 by adding daily as well as PRN cleaning of the endotracheal tube prior to spontaneous breathing trials. Although it is intuitively obvious that earlier extubation and hospital discharge results in significant cost savings, let's look at some examples. These 4 hospitals employed protocol ET tube cleaning with an ENDOCLEAR device at the time of the morning spontaneous breathing trial, and they compared their outcomes and cost to the time period immediately before the protocol cleaning was instituted. The per case cost benefit is reported, and all financial data were provided by each individual institution. This somewhat busy slide provides hospital cost savings detail and looks specifically at duration of mechanical ventilation, ICU length of stay, hospital length of stay, and direct hospital costs that were experienced at these 4 institutions. This study is from an Adventist West hospital facility and was recently presented at the American Thoracic Society meeting in Washington, D.C. in May. Data from the trial period showed that like DRG patients saw decreases in all length of stay. The average duration of mechanical ventilation was reduced by 1.1 days, the ICU average length of stay was reduced by 0.3 days, and the hospital average length of stay was reduced by 0.8 days. In this analysis, they also found that their reintubation rate decreased and their ICU readmissions decreased. We can see that decreasing the average length of intubation by 1.1 days, which was statistically significant, resulted in 202 total days of ventilation saved over the 3-month trial period. As the incremental cost of being intubated while in the ICU is approximately $1,500 per day, the estimated savings from this 90-day study was $308,000. Over a 12-month period, this would amortize to a hospital savings of over $1 million. This is an example of what decreasing average length of intubation can do for an individual hospital. This shows an average size hospital in which the number of ventilator patients per year is 1,000, ventilator days per year is 4,000, and the average initial length of intubation is 4.0. Protocol use of the ENDOCLEAR Liberator System at that hospital for a year would be approximately $86,000. The bottom portion of the slide shows that if the average length of intubation only decreases by 0.25 days which is less than we have shown at any other hospital using the products in protocol fashion. The cost savings calculated for the direct care of these patients would be $375,000. When one looks at the return on investment for the facility, it becomes 4.3 times. As the average length of intubation decreases even further, the return on investment amplifies. Closed suction has been the standard of care for maintenance of the artificial airway for several decades, but as we have seen, it is inadequate to do so. The ENDOCLEAR Liberator System can provide safer airway management, improved patient outcomes, and lower hospital costs. Thank you.